Namaste students. Today we will be discussing one very important case from a postgraduate students. Okay, the history and interpretation will be asked in a postgraduate level, but for undergraduate level they may keep this case as a short case just to examine the motor system and sensory system they may keep. But for a postgraduate student, they will keep this case for a detailed discussion, differential diagnosis, analysis on the examination. Okay. So let us go ahead with the central nervous system case. Today what we will be discussing. The patient name is XXY and she is aged about 48 years. She is a female and her occupation, she is attender in a medical college. Address, she is from the Bangalore. The history is given by herself and it is reliable. The presenting complaint, patient was apparently normal till 2009 when she started noticing tingling and numbness of the left lower limb. She used to get like electric shock like sensation of the left lower limb from the back till the foot. So, patient was apparently normal till 2009 when she started noticing tingling and numbness of left lower limb. She used to get electric shock like sensation of the left lower limb from back to the foot. And this electric shock like sensation, whatever she used to get in the left lower limb, sometimes it used to be associated with the numbness of the left foot, especially when she used to walk for a longer period. So when she used to walk for a longer period, she used to experience the numbness of the foot. That numbness of foot which she used to experience after walking for a longer period used to subside after taking the rest. Whatever the pain, she is saying the tingling and numbness and electric shock like sensation, it is present in standing, even in sitting position according to her it is present, and even during sleeping also it is present according to her. And but that pain, whatever the electric shock like sensation and tingling and numbness, it increases on walking according to her. It increases on walking. This pain, whatever she is having in the left lower limb, it has no relation to the coughing, bending or sneezing. Why it was this history? Okay, the root pain, the radicular pain, okay, which is compressed by the extramedullary compression in the spinal cord. When they have a root pain, this will be like electric shock like sensation, whatever she is experiencing, but that will increase with bending, coughing, sneezing. But our patient, she says, has no relation with coughing or sneezing, and she says it is present even in sleeping, sitting, standing position, it is present. The patient says the pain, whatever she is having, the left lower limb electric shock sensation, it has no relation with either climbing up the stairs or climbing down the stairs. Why this point is important, climbing up the stair or climbing down the stair? Because whenever a patient has a pain like this, you have to distinguish whether it is a neurological claudication or a vascular claudication. A vascular claudication will increase with climbing up the stairs, whereas a neurological pain will increase with climbing down the stairs. So that point is important. Patient says there is no issue of pain in the right lower limb or there is no pain in both the upper limb. So both the upper limb and the right lower limb are absolutely normal. It is not at all involved. And she says if she walks for a longer period, she doesn't stoop, because after walking for a longer period, whenever they get a neurological claudication, and after that, if still they walk, they'll walk with a stooped position in lumbar canal stenosis. So that point is important. And one more point is, she says that whatever left lower leg pain she has, it increases on prolonged standing. This history is important because it is also known as a cocktail syndrome. After prolonged standing, neurological claudication will increase. It is cocktail syndrome. A neurological claudication will increase after a prolonged standing. She says that it increases on prolonged standing. Then the associated symptom which I asked after walking for a longer period, the numbness, whatever she told, the paresthesia, in a male, the priapism or incontinence. These are the associated symptoms what you get in neurological claudication, but not in a vascular claudication. Okay, the associated symptoms like priapism, incontinence, or paresthesia. She says after walking for a longer period, there is a numbness. Okay, and it reduces with taking the rest. After discussing the history, I'll discuss how to distinguish a vascular claudication from a neurological claudication. For the timing, each symptom, whatever she is having, I'm trying to correlate with whether she is having vascular or neurological. In the end, I'll discuss again. She says there is no symptom suggestive of a motor weakness in both upper limb and lower limb. That means in the upper limb, the proximal, she can lift the hand above the head. In the upper limb, she can mix the food, button or unbutton with her fingers, her dress. In the lower limb, she can get up from the sitting position, no weakness. This is in 2009, what I am telling. Whenever she had this left lower leg pain, the electric shock like pain, she could get up from a sitting position and she could hold the chappals tightly. The gripping is normal. So, no motor weakness, either proximally or distally, both in upper limb and lower limb in 2009. Pain, whatever she had, this left lower leg pain, it was insidious in onset and gradually progressive. She told over 3 months the pain started insidiously and slowly progressed. There is no history of stiffness of both the lower limbs, which indicates the corticospinal tract involvement. History of stiffness you have taught. There is no history of stiffness in this patient in both the lower limbs. No history suggestive of any sensory loss. She could appreciate the cloth sensation, which is a fine touch. Hot and cold water during bath she can appreciate, which carries spinothalamic pain and temperature. She can appreciate the hot and cold water sensation. Okay. And she can appreciate the touch sensation. There is no history suggestive of any sensory disturbance. And one important point in this case is whether there is any sensory disturbance in a saddle area, okay, the buttocks area. She says while washing, after going to defecation, she can appreciate the water sensation, if it is hot or cold water. And she can appreciate the sensation over the buttocks area. So there is no symptom suggestive of saddle anesthesia. This is very important, okay, to distinguish whether she has a cona or cauda equina lesion. Very important history-wise. No history suggestive of bowel and bladder involvement. Again, very important. Bowel and bladder can be involved in a conus lesion, or his spinal cord is involved by the compression. Bowel and bladder can be involved. So that history is important, but she doesn't give any history of bowel and bladder involvement. Okay. No history symptom suggestive of cranial nerve abnormality. She doesn't give any symptom suggestive of cranial nerve involvement. Not involved. For the above complaint, whatever she had, this electric shock sensation, unbearable without sleep for the 3 months, she approached a doctor when they did a MRI in 2009 and they advised she has to undergo surgery. Okay. She underwent operation in 2009 in one of the hospitals in Bangalore. After she recovered from anesthesia, immediately after the operation, she noticed she couldn't lift her left foot above. Her left foot she couldn't lift above. Okay. In our medical terminology, dorsiflex. Okay, she couldn't do that according to her once she regained the anesthesia. But though she couldn't lift her left foot above, there was no sensory abnormality. Okay, she could appreciate the hot and cold water on that left foot. Even cloth she could appreciate on the left foot. No sensory abnormality. There was only a motor weakness of the left foot according to her. And she noticed after that, since 10 years, below the knee, the left leg has become small compared to the right leg. It has become small compared to the right leg. After operation, however, she says there is a reduction in her electric shock-like sensation which she was experiencing in the left lower leg. Okay? The left lower leg pain, it reduced, whatever she had. And even after developing this left foot where she couldn't move upwards, it was not associated with any bowel or bladder involvement. No bowel or bladder involvement. And there was no saddle anesthesia even after she developed this left foot where she couldn't lift it upwards. There was no saddle anesthesia even after the operation. Some of the important negative points in the history: no history of trauma to the back. No history of fever or weight loss, because in India very important. One of the common cause of compression at the spinal cord producing radicular pain like this is tuberculosis. So history of weight loss and the fever you tossed. No history of weight loss, anorexia, again secondaries can go and compress in the spinal cord producing a root pain like this. So that history is very important. No history of joint pain or skin lesions. Joint pain, connective tissue diseases like rheumatoid arthritis can produce a mononeuritis, paralyzing the leg, whatever she is having, the dorsiflexion of the foot. The leprosy can produce mononeuritis involving the whatever the weakness she is giving complaint in the left foot. And no history suggestive of symptoms of diabetes mellitus like polyuria, polyuria. Why that is important? Diabetes again can produce a mononeuritis, producing the weakness of whatever the motor weakness she is saying in the left foot. So these are some of the relevant negative points. I'll go through the other part of the history and then I'll come to the analysis of the history. Past history, she is not a diabetic, hypertensive or tuberculosis. Personal history, diet, she takes a mixed diet. Bowel and bladder is normal. Sleep, in 2009 when she had that lancinating pain, electric shock like pain, it was disturbed due to the pain. Addictive habits, not an alcoholic or smoker, no high risk behavior. Family history, there is no significant family history. Menstrual history, she attained age of menarche at 16 years. Periods are normal, no menorrhagia. Treatment history, nothing significant apart from the surgery which she underwent in 2009 for her spinal cord problem. Okay. Now, summary of the history. She says electric shock like sensation in the left lower limb. So that is looks like a root pain according to our symptom. How do you describe a root pain in CNS? A root pain will be in a dermatomal distribution, electric shock like sensation, which increases with coughing, sneezing, and bending down. 2009 is a very long history. Probably she may not be remembering whether with cough or sneezing it increases, but now when I asked, she is telling with cough and sneezing it has no relation. Probably it might have had a relation, we don't know. But a classic root pain with cough and sneezing, Valsalva minor, it should increase because the pressure will transmit it from the CSF, the spinal cord to the roots, so they should increase with the bending down, cough, sneezing, and Valsalva minor. Then there are some 5 to 6 standard questions which will be asked in the exam if you get a case like this for a postgraduate level students. One is, what are the different pains you get in CNS? This is a standard question. So what are the different pains you get in CNS? One is a root pain like this, root pain. Another is, if there is a compression on the dorsal column, of the spinal cord, there will be a band-like sensation at that level, a band-like, sensation at that level. That is another cause of CNS pain. Then the third is, in an intramedullary tumor, whenever there is a expansion, they'll get a funicular pain, which is a dull aching pain. A funicular pain is a dull aching pain. Then you have peripheral neuropathic pain you get. A thalamic pain, if right thalamus involved, left side of the body, they'll have a severe pain, though there is a loss of sensation to all modalities, they'll have a severe pain, thalamic pain. So there are some of the pains what you get in CNS. This question they'll ask. So it looks like she is having a root pain or radicular pain. Now, the another thing in this case is you have to distinguish whether it is a neurological claudication or a vascular claudication. Again, this is a standard question which will be asked in the exam. All postgraduates should know. Students, if you know 5-6 standard questions, if you get a case like this, you will be passed and some basic examination things. So what are the difference between neurological claudication and a vascular claudication? First is the site. A neurological claudication will be bilaterally symmetrical. It can be unilateral, but it can be bilateral. The site is gluteal region, back of the thigh and leg. Whereas In a vascular claudication, the site is in the calf muscle and it will be asymmetrical vascular claudication pain. Then the aggravating and relieving factors. Neurological claudication will increase with standing and walking, and it relieves with sitting and lying down. Whereas a vascular claudication will reduce with stopping of the exercise. It has no relation with standing. Okay, whereas a neurological claudication will increase with standing. Then walking up the hill, vascular claudication will have pain. And neurological claudication, walking down the steps, they will have pain. Then long standing in a neurological claudication, as I told, cocktail party syndrome, it will aggravate the pain in a neurological claudication. Then for a relief of the pain, it takes minutes in a neurological claudication, whereas it is immediate in vascular claudication to relief of the pain. Then associated symptoms. Associated symptoms in a neurological claudication, if you ask the patient to walk for some distance, they'll have the paresthesias, priapism, incontinence. But the associated symptom is not a feature in vascular claudication. Then examination after exercise. If you examine the patient after exercise, in a neurological claudication, there will be absent sensation or absent reflex or a weakness, but not in vascular claudication. Then if you examine the pulse will be absent in a vascular claudication, but in neurological claudication, pulse will be present. Then the back hyperextension. Hyperextension of the back will aggravate the symptom in neurological claudication, but not in vascular claudication. Students, all the differences I have taken from a Dijon, okay? So you have to go back, read again, and you memorize it, okay? This question will be asked in the exam, okay? So our patient looks like she is having a neurological claudication because on walking for long distance, she is developing numbness, and that numbness reduces with taking rest, and for a prolonged period, she is experiencing the numbness, okay? So these are some features which is fitting into the neurological claudication. So this question will be asked, okay? The neurological claudication and vascular claudication. And then here, whether she is having any spinal cord symptom, see, there is a definitely root is involved by a compression. A root is involved. Whether spinal cord is involved or not. Spinal cord involved, she is not giving any stiffness history. She is not giving any bone and blood history. History wise, it doesn't look like myeloradiculopathy. It looks like only radiculopathy. Okay, looks like only radiculopathy, but not a myeloradiculopathy. Then another two standard question which will be asked in the exam and you have to interpret in this sort of cases is whether it is a compressive myelopathy or non-compressive myelopathy. In the history wise, how do you distinguish a compressive myelopathy from a non-compressive myelopathy? In a compressive myelopathy, root pain will be there. She is having a root pain, whereas in non-compressive myelopathy, no root pain. And in a compressive myelopathy, it will be asymmetrical. See our patient, only one leg, left leg, and root pain. So it's compressive. Very simple history wise. Asymmetrical, one leg is involved and there is a root pain. This is compressing from something outside. If it is non-compression, it will be bilaterally symmetrical and no root pain. Again, a standard question, a PG level should know. Then, in the compression, whether extramedullary or intramedullary. In the history wise, whether you can distinguish extramedullary or intramedullary compression. There are some features to distinguish extramedullary from intramedullary compression. As I told, sensory symptom, extramedullary, there will be a root pain, a radicular pain will be there. Whereas in intramedullary, a funicular type of pain will be there. A dull aching funicular type of pain. Then the sensory loss, in extramedullary compression, from one side the spinal cord will be compressing. So ipsilateral, they will have loss of fine touch and vibration. Contralateral, pain and temperature. That is a mode of sensory loss in extramedullary compression. Whereas in intramedullary, there will be dissociated anesthesia. Pain and temperature will be lost. Fine touch and vibration will be preserved. A dissociated anesthesia is seen in intramedullary compression. Then Because of the arrangement of fibers, in the intramedullary fibers, sacral fibers are away in the spinal cord. So they are the last to involve. So sacral sparing is a feature of intramedullary compression, but not extramedullary. Extramedullary, the sacral fibers will be involved. There will be early involvement in the sacral area, saddle area, in extramedullary compression. As intramedullary, sacral sparing will be there. Our patient anyhow, he is not having any sacral involvement. Then LMN and UMN signs. In an intramedullary compression, UMN signs will predominate at that level and also extensively. LMN signs will predominate. Whereas UMN signs will predominate in extramedullary compression with exaggerated reflexes, spasticity. LMN signs is not that much predominant in extramedullary compression. Then tropic ulcers, decubitus, is a feature of intramedullary compression but not extramedullary compression. Okay, so these are some of the differences between intramedullary compression and extramedullary compression. Okay, so here history-wise it looks like extramedullary because there is a root pain, there is no dissociative anesthesia in there. Okay, and no sacral sparing. History-wise it looks like extramedullary compression, compressing the root. Then because she has a pain in the electric shock-like sensation in the left lower limb, okay. Another question which will be asked is a conus and cauda equina. Whether she belongs to that conus or cauda equina. Again, all these things I will discuss again. It is important not only today when I take the other spinal cord cases also, because these questions you should memorize, you should know, you should analyze, and you should know these 4-5 questions. So conus and what is conus? Conus is S3, S4, S5. The spinal cord is conus. Cauda equina is the roots from L1 down. All the roots, spinal roots is cauda equina. So what are the difference between conus and cauda equina lesions? What are the differences? There will be a saddle anesthesia. A sensory symptom is not that much predominant in a conal lesions. Whereas in a cauda equina there will be asymmetrical root pain will be there. Symmetrical loss of sensation in a conus lesion. In a cauda it will be asymmetrical. One leg will be involved with a predominant sensory loss. And in a cauda, all modalities will be lost. Pain, temperature, fine touch, vibration. Whereas in a conus, there will be dissociation of the anesthesia. Pain and temperature will be lost in a conus lesion. In a conus lesion, because S3, S4, S5 supplies the bowel and bladder and sexual dysfunction will be there in a conus lesion, but not a feature in cauda equina. The muscle involvement will be less in a conus lesion because S3, S4, S5 doesn't supply any major limb muscles, whereas in a cauda, there will be predominant wasting of the thigh muscles in a cauda equina lesions. Then again, as I told, dissociation of the anesthesia. Then in a conus lesion, there can be absent ankle reflex, especially epiconus, because L5S1 is the root value of ankle reflex. Conus is S3, S4, S5. L5S1 is the ankle reflex. There is one syndrome called epiconus. There can be absent ankle reflex. But in a cauda equina, there will be both patellar and ankle reflex will be absent. In a cauda equina, both ankle reflex and patellar will be absent. Though examiners are fancied in asking this question, conus and cauda, clinically they won't occur separately. And even De Jong, all these answers are taken from De Jong, conus and cauda, extramedullary, intramedullary compression, neurological claudication, vascular claudication. Conus and cauda doesn't occur separately in clinical entities. For example, infiltration by lymphoma or neurofibromatosis produce a combination. It is called, that's why sometimes it is called as conus cauda lesions. It is called as conus cauda lesions. But anyhow, as a postgraduate, you should know the differences between these three things. And there is something known as epiconus, and you should know the difference between epiconus and conus lesions. Conus is S3, S4, S5. Epiconus is L4, L5, S1, S2. L4, L5, S1, S2. So what is the difference between conus and epiconus? In a conus, as I told, bowel and bladder will be involved and sexual dysfunction. With epiconus, that won't be involved. In a conus, ankle reflex will be present because it is only S3, S4, S5. L5, S1 is the root for ankle reflex. In epiconus, ankle reflex will be absent. So there is some difference between conus and epiconus. And one more difference between the conus and cauda is conus will be usually acute causes and cauda will be a chronic causes. Cauda will be a chronic causes. Okay. So now in the compression, we discussed the compressive myelopathy, non-compressive myelopathy. And in the compressive, extramedullary, intramedullary. In extramedullary are two things. One is intradural, extradural. It can be within the dura mater, which covers the spinal cord, or away from the dura mater. So what are the differences? Usually intradural will be benign lesions, extradural will be malignant lesions. So benign lesions, it takes a longer period to develop. Extradural will be usually acute conditions. And they'll have vertebral pain in extradural compression, no pain in intradural compression. And extradural is bilateral, intradural can be unilateral. So some of the difference between intradural and extradural compression. So all these questions are very important, students, for your postgraduate level students. Okay, you should know thoroughly. Again, I'll discuss these questions when I take the other compressive myelopathy and non-compressive myelopathy cases. I'll discuss one transmyelitis, one hereditary spastic paraplegia. Again, I'll discuss these questions, which you should know at postgraduate level, fingertips. Okay. So our patient has a root pain, asymmetrical. So it is a compressive myelopathy. Okay. Compressive myelopathy. And it is a radiculopathy. There is nothing to suggest spinal cord is involved, only roots are involved because no ball bladder involvement, no stiffness in the history wise. Let us see on the examination. That is one point. That radiculopathy is what she had in 2009. But after the operation, she gave history. Suddenly after the operation, she has developed she cannot move the foot upwards. For spinal cord, they do laminectomy. After laminectomy, she has developed the upward movement of the foot. So after the operation, she has developed the weakness of the upward movement of the foot. So after the laminectomy, she has developed the foot drop. So probably it is a iatrogenic foot drop with the commonest root, a unilateral foot drop is L5. L5 radiculopathy for a foot drop. Probably she might have developed that problem because of the laminectomy. Okay. So it's a history analysis. Let us see an examination, what findings we get. Okay. And what will turn out to be after investigations. But a very good case for a postgraduate level. Okay. So let us go with the examination. A 48-year-old female, conscious and cooperative, history given by herself and reliable. She is a right-handed person. Vitals, pulse is 84 beats a minute, regular, volume is good, no radial, no femoral delay, no pulse deficit, vessel wall is not thickened. Blood pressure 130 by 80 mmHg. Temperature, she is afebrile, respiratory rate 18 cycles per minute. Head-to-toe examination, let me just quickly go through what are the relevant things you want to see in this patient. So, what are some relevant things what we look in this case, general physical examination? Okay, let me look for pallor, kanmel nodiyama, kan kaliga nodi, no icterus, no pallor, nalge torsi, no cyanosis, lymphadenopathy, no lymphadenopathy, no clubbing, torsi. No clubbing, students, and no pedal edema. Okay. So this in general you look the pallor, edema, icterus, lymphadenopathy and cyanosis. Pertaining to this case, what are the things you have to look in general physical examination? See, you are thinking a compression, okay, at the spinal cord level. So in India, you would always ask, in the history wise we ask fever and weight loss, tuberculosis. So stigmata of tuberculosis, like frictional conjunctivitis, erythema nodosum, scrophaloderma, lupus, you have to see. Okay. Then again, nowadays it is rare, but before it was there, that is syphilis. Okay, especially in a male patient, you have to look for the healed scar of chancre is there, you have to look in a male patient. Then thickened nerves, because she has developed the weakness of the upward movement of the foot, we are thinking a foot drop, a mononeuritis can be produced by leprosy. So, you have to look for thickened nerves, okay, thickened nerves in the neck and common peroneal nerve in the leg and in the ulnar nerve against the olecranon. So thickened nerves you should look. She is not having any thickened nerves or any skin patches for a leprosy. You have to look for any skin patches for the leprosy. And you are thinking a compression of the spinal cord, a fluorosis, again common in some of the endemic areas in India. Okay, a fluorosis, general physical examination, you will look for a exastosis, whether she has any exastosis. So that you have to look. She is not having any exastosis. Okay, right. And as usual, in any CNS case, the neurocutaneous markers like neurofibromatosis, because it can present the spinal cord, especially relevant in this case. So whether she has any caféole or spots, the neurocutaneous markers, ataxia telangiectasia, tuberous sclerosis. So neurocutaneous markers you have to look. So pertaining to this case, stigma of tuberculosis, thickened nerves, skin patches, neurocutaneous markers, and in a male, the healed chancre, and exastosis for fluorosis. Some of the relevant points in top to bottom what you have to look in this case in general physical examination. Okay. So coming to the central nervous system examination, high mental function, she is conscious and she is a right-handed person. Attention and consciousness, mini mental status examination, she scored 27 out of 30. Language, there is no dysarthria or aphasia. It's normal. Memory, recent, remote and immediate memory is normal. Construction is normal, abstract thinking is normal, insight and judgment is normal. So she is not having any higher mental function abnormality. Cranial nerves, history she didn't give any symptoms suggestive of cranial nerves. An examination also, olfactory nerve is normal, optic nerve, visual acuity is normal, color vision normal, field of vision and pupillary reflex is normal. Oculomotor nerves 3/4 and 6. Extraocular movements are normal, no nystagmus. Fifth nerve, the motor examination is normal. Sensory part is also ophthalmic, maxillary, mandibular sensory examination is normal. The corneal reflex, conjunctival, jaw jerk is normal. Seventh nerve, she can close the eyes forcefully. There is wrinkles on the forehead. She can hold the air in her cheeks. So motor part of the examination of seventh nerve is normal. Sensory part also taste she can appreciate. Eighth nerve, Rene AC is better than BC. Weber's lateral is equal to both the sides. Ninth and 10th, gag reflex is normal. 11th nerve, she can shrug the shoulder. 12th nerve is also normal. So cranial nerves, symptom she didn't give any history. On examination also cranial nerves are normal, students. So next is motor system. Okay, students, motor system examination, nutrition. Upper limb, arm is 27, right side, left side is 26.5. Forearm, right side is 21, left side is 20.5. Lower limb, very important because history she told, she herself noticed the left leg below the knee has become small. So let us see on examination how much it is. Left, the lower limb, the thigh, right side is 44, left side is 43.5. The leg, right side is 32, left side is 28. So there is a wasting. So it is an element. Okay, so there is a wasting. So there is a element weakness of the left lower limb. Okay. Tone, upper limb tone is normal, students, but left lower limb there is hypotonia. The tone, the right side normal, appears normal. Left side also normal. Lower limb tone is coming along the ground, it is normal. Even you can check okay. The left side, yeah, it appears normal. The tone is normal. Right, the left lower limb is also normal. Now coming to the power examination, students. History she told upper limb is absolutely normal. She can lift the hand above the head. She can mix the food with the hands. So on examination also, shoulder joint, abduction and adduction, both right side and left side is 5/5. Shoulder joint, flexion, extension, both right and left side is 5/5. Pectoralis major, 5/5 both the sides. Deltoid 5/5. Latissimus dorsi 5/5, rhomboids major, serratus anterior, infraspinatus is 5/5 both right and left side. I am not going detail to the examination of the muscle examination because history she didn't give any symptom. On examination it is normal. I have discussed the examination of the muscle power examination in the myasthenia gravis, dermatomyositis. Again, I am going to discuss in one more muscle dystrophy which I discussed. In this case, it is not important to demonstrate too. That's why I am not demonstrating it, but it is I examined it is normal. 5/5 the power is normal in the upper limb. In the elbow joint, elbow flexion, extension 5/5 both right and left side. Wrist flexion extension is 5/5 and small muscle hand grip is normal both right side and left side. Okay, but in the lower limb I'll show because her problem is weakness in the lower limb. Upper limb she told it is normal, but in the lower limb there is a weakness. Lower limb I'll examine the power. Okay, right. Okay, ಈ ಕಾಲು ಇದೆಯಲ್ಲಮ್ಮ ನಾನು ಹೇಳಿದಾಗ ಇಲ್ಲಿ ಮಡಚಬಾರ್ದು, ಹಿಂಗೆ ಸ್ಟ್ರೈಟ್ ಎತ್ತಬೇಕು. ಓಕೆ, ಇಲ್ಲಿ ಮಡಚಬಾರ್ದು. ಸೊ ಹಿಪ್ ಫ್ಲೆಕ್ಷನ್ ಅಮ್ಮ ನಾನು ಹೇಳಿದಾಗ ಈ ಕಾಲನ್ನ ಈ ಥರ ಎತ್ತಬೇಕು, ಇಲ್ಲಿ ಮಡಚಬಾರ್ದು ಮಂಡಿ ಎತ್ತಿ. ಹಾಂ, ಓಕೆ, ಎತ್ತಿ ಮೇಲಕ್ಕೆ ಎತ್ತಿ. ಯಾ, ಶಿ ಕ್ಯಾನ್ ಲಿಫ್ಟ್ ಇಟ್. ಇಟ್ ಇಸ್ ನಾರ್ಮಲ್. ರೈಟ್ ಸೈಡ್ ಫ್ಲೆಕ್ಷನ್ is normal. Let me do the left side. Okay, she can lift it. It is normal. The left side also flexion is normal. Hip flexion is done by iliopsoas psoas. Hip extension you have to make prone and elevate the whole leg. I examine in her. Okay, I don't want to trouble again. Okay, hip extension is also normal. Let me do hip abduction adduction. Okay, hip abduction adduction. ಅಮ್ಮ ನಾನು ಹೇಳಿದಾಗ ಈ ಕಾಲಿದೆಯಲ್ಲ ಹಿಂಗೆ ಅಗಲ ಮಾಡಬೇಕು ನಾನು ಹೇಳಿದಾಗ. ಓಕೆ, ಮಾಡಿ. ಯಾ, ಶಿ ಇಸ್ ಡೂಯಿಂಗ್ ಇಟ್ ಇಸ್ ನಾರ್ಮಲ್. ಓಕೆ, ಈಗ ಹಾಗೆ ಇರಲಿ, ಹಿಂಗೆ ಒಳಗಡೆ ತೊಗೋಬೇಕು ನಾನು ಹೇಳಿದಾಗ. ತಗೊಳ್ಳಿ. ಯಾ, ಶಿ ಇಸ್ ಡೂಯಿಂಗ್ ಇಟ್. ಹಿಪ್ ಅಡಕ್ಷನ್ ಈಸ್ ನಾರ್ಮಲ್. ಹಿಪ್ ಅಡಕ್ಷನ್ ಈಸ್ ಬೈ ಅಡಕ್ಟರ್ ಮ್ಯಾಗ್ನಸ್, ಬ್ರೀವಿಸ್, ಅಡಕ್ಟರ್ ಗ್ರೂಪ್ ಆಫ್ ಮಸಲ್ಸ್. ಹಿಪ್ ಅಬ್ಡಕ್ಷನ್ ಈಸ್ ಬೈ ಗ್ಲೂಟಿಯಸ್, ಮೀಡಿಯಸ್ ಅಂಡ್ ಮಿನಿಮಸ್. ಸೊ ಹಿಪ್ region everything is normal. So let me examine in the knee flexion, knee extension. Knee extension, ಕಾಲು ಮಡಚ್ಕೊಳ್ಳಿ ಅಮ್ಮ. ಕಾಲು ಸ್ಟ್ರೈಟ್ ಮಾಡಿ. ಮಾಡಿ. knee extension normal, right side, left side let me examine. ಕಾಲು ಮಡಚ್ಕೊಳ್ಳಿ, ಸ್ಟ್ರೈಟ್ ಮಾಡಿ, ಸ್ಟ್ರೈಟ್ ಮಾಡಬೇಕು. left side is also normal. Knee extension is by quadricep group of muscles. Knee flexion I'll demonstrate. Knee flexion normal students. Okay, ಸಾಕು ಬಿಡಿ. ಈ ಕಾಲು ಮಡಚ್ಕೊಳ್ಳಿ. Good. This is also normal. Let me examine for the internal rotation here only. Good. Normal internal rotation. Let me check this side also. Good. Nice. Yeah. So students, knee joint, the flexion, extension, internal rotation is normal. Let us examine the important now, the ankle joint. What has happened to the ankle joint? Because this way she says the foot only she cannot move it upwards. So what has happened? Especially left side she told. Students, now let me examine the dorsiflexion on the right foot. Melek ಮಾಡ್ಕೊಳ್ಳಿ. She can do it. You can make students, she can do the dorsiflexion. So nice. Let me examine the plantar flexion on the right foot. ಕೆಳಗಡೆ ಮಾಡಿ ಪಾದ. She can do it, plantar flexion. So right foot dorsiflexion, plantar flexion is normal. Let me examine the left foot. ಅಮ್ಮ ಕೆಳಗಡೆ ಪಾದ ಇದೆಲ್ಲ ಮೇಲಕ್ಕೆ ಮಾಡ್ಕೊಳ್ಳಿ. ಮಾಡಿ. She is telling ಮೇಲ್ ಬರಲ್ಲ. That is she cannot do it. So left foot she cannot do the dorsiflexion. There is a weakness. Okay students. Let me examine the plantar flexion. ಈಗ ಈ ಪಾದ ಇದೆಯಲ್ಲ ಕಮಲ ಹಿಂಗೆ ಕೆಳಗೆ ಮಾಡ್ಕೋಬೇಕು. ಮಾಡಿ. She can do it. She can do the plantar flexion. So only dorsiflexion is a problem. Okay. She was also, she told she couldn't move the foot upwards. There is a dorsiflexion is a problem. Let me check for the immersion eversion. ಕಮಲ ಈ ಪಾದ ಇದೆಯಲ್ಲ ಈ ಸೈಡ್ ಹಿಂಗೆ ಮೇಲಕ್ಕೆ ಮಾಡ್ಕೋಬೇಕು. ನಾನು ಹೇಳಿದಾಗ ನಾನು ಕೆಲಸ ಔಟ್ ಸೈಡ್ ಮೇಲಕ್ಕೆ ಮಾಡ್ಕೊಳ್ಳೋದಾಗ ಹಿಂಗೆ ಮಾಡ್ಕೋಬೇಕು. ಕಮಲ ಈ ಒಳಗಡೆ ಪಾರ್ಟ್ ಮೇಲಕ್ಕೆ ಎತ್ತಿ. ಓಕೆ, ಹೊರಗಡೆ ಪಾರ್ಟ್ ಮೇಲಕ್ಕೆ ಎತ್ತಿ. ಹಂಗಲ್ಲ, ಒಂದು ನಿಮಿಷ ಹೇಳ್ತೀನಿ ಬಿಡಿ. ಹಿಂಗೆ ಮಾಡಬೇಕು. ಒಳಗಡೆ ಅಂದಾಗ, ಹೊರಗಡೆ ಅಂದಾಗ ಹಿಂಗೆ ಮಾಡಬೇಕು. ಓಕೆ, ನಾನು ಹೇಳ್ದೆ ಒಳಗಡೆ ಪಾರ್ಟ್ ಮೇಲಕ್ಕೆ ಎತ್ತಿ ಇನ್ವರ್ಷನ್, ಹೊರಗಡೆ ಪಾರ್ಟ್ ಮೇಲಕ್ಕೆ ಎತ್ತಿ ಎವರ್ಷನ್. ಶಿ ಇಸ್ ಏಬಲ್ ಟು ಡೂ ಇನ್ವರ್ಷನ್ ಎವರ್ಷನ್ ಆನ್ ದ ರೈಟ್ ಸೈಡ್. ಲೆಟ್ ಮಿ ಚೆಕ್ ಆನ್ ದ ಲೆಫ್ಟ್ ಸೈಡ್. ಈಗ ಈ ಒಳಗಡೆ ಪಾರ್ಟ್ ಮೇಲಕ್ಕೆ ಎತ್ತಿ ಆಗಲ್ವಾ, ಹೊರಗಡೆ ಪಾರ್ಟು she can't do left side the inversion and eversion. Okay, that's the problem she is having. So this finding is very important in this case, students. The dorsiflexion is not able to do that. Okay, right. Then extensor hallucis longus also you have to test. Extensor hallucis longus, let me test for that. ಕಮಲ ಈ ಬೆರಳಿದೆಯಲ್ಲ, ನಾನು ಹೇಳಿದಾಗ ಹಿಂಗೆ ಮೇಲಕ್ಕೆ ತರಬೇಕು. ಓಕೆ, ತಗೊಂಬನ್ನಿ ಮೇಲಕ್ಕೆ, ಬೆರಳು ಮೇಲಕ್ಕೆ ತಗೊಂಡು ತಾನೆ. ಶಿ ಇಸ್ ಏಬಲ್ ಟು ಡೂ ದಟ್. ಈ ಕಾಲ್ ಮೇಲೆ ತಗೊಂಬನ್ನಿ, ಈ ಬೆರಳು ಆಗಲ್ಲ. ಶಿ ಕಾನ್ ಡು ಎಕ್ಸ್ಟರ್ನಲ್ ಹ್ಯಾಲಿಸಿಸ್ ಲಾಂಗಸ್. ಓಕೆ ಸ್ಟೂಡೆಂಟ್ಸ್, ಎಕ್ಸ್ಟರ್ನಲ್ ಹ್ಯಾಲಿಸಿಸ್ ಲಾಂಗಸ್ ಇಸ್ ಎ ಪ್ರಾಬ್ಲಮ್. ಸೊ ದಟ್ ಈಸ್ ಅಬೌಟ್ ದ motor power examination. Now next, coordination. Coordination, there is no nystagmus. Titubation, there is no titubation, no dysarthria and no tremors. And the other cerebellar signs, finger nose test, finger nose finger, heel knee test, dysdiadochokinesia, Ohm's rebound phenomena, pendulum knee jerk, macrographia is not there. Cerebral system examination is normal. History is also, she didn't give any history of ataxia or imbalance. Okay, so the cerebral system examination is normal. Next, coming to the reflexes. Reflexes, superficial, corneal is normal, conjunctival is normal, the gag reflex is normal, abdomen is also normal. Plantar is important because whether it is pressing a spinal cord or only root. If it's pressing a spinal cord, the compression what we are thinking, then plantar should be extensor. Let us see whether it is there or not. So plantar, let me examine. ಏನಾಗುತ್ತೆ ಬಿಡಿ, ಏನು ಮಾಡಲ್ಲ, ಮೆತ್ತಗೆ ಮಾಡ್ತೀನಿ. ಫ್ಲೆಕ್ಸಾರ್, flexor, right side. Left side, here even if it is extensor you may not get, because extensor hallucis longus is paralyzed. Okay, that is, it is not moving neither upwards or downwards. Okay, the left foot, see, neither it is moving upwards or downwards because it is paralyzed. Extensor hallucis longus. Okay, right, the left great toe is paralyzed. And in a sort of these sort of cases, ideally you have to do a anal reflex. Okay, with a glove you have to insert your finger to the, you have to do a PR, and surrounding the anal region you have to scratch, and you will feel the sphincter contraction. S3, S4, S5 mediated by S3, S4, S5 anal reflex. And in a male patients, bulbocavernosus reflex. You have to pinch the glands, then you have to look for the bulbocavernosus reflex, the corpora cavernosa contraction at the base of the penis. In a male patient, you do that. Okay, because you are thinking a conus cauda lesions in these sort of cases, you have to do those superficial reflexes. Let me examine the deep tendon reflexes. Okay, so I'll do important reflexes: biceps, triceps, brachioradialis, knee and ankle jerk. Okay, right side biceps is present. Brachioradialis is present. Let me examine the ankle jerk. ಸುಮ್ಮನೆ ಆರಾಮಾಗಿದೆ, ಏನು ಮಾಡಲ್ಲ. Triceps present, you can make out nicely. Left side biceps, she is wearing cloths and that is not able to make the contraction. Let me check the triceps. ಆರಾಮಾಗಿದೆ, you can see the contraction, student. Triceps nicely present. Through the cloth only you can make out the contraction. Okay, triceps nicely present. Yeah, let us examine the knee jerk and ankle jerk. Yeah, let me examine the knee jerk. Present, students, you can make out the contraction. See, nicely present. Yeah, you can make out the contraction. One knee jerk is present, right? See, it is present. Let me examine on the left side. ಆರಾಮಾಗಿರಿ, ಏನು ಮಾಡಲ್ಲ, ಟೈಟಾಗಿಡಿ ಬಿಡಿ ಅಷ್ಟೆ. Present, students, nicely you can make out. Actually it is brisk. See, is brisk. I'll compare with the right side. It's just present right side. Here also brisk. Any clonus is there? Let me check. No clonus. Ankle jerk I'll show. Next. ಸುಮ್ಮನೆ ಏನು ಮಾಡಿ ಶೀಸ್ ಹೋಲ್ಡಿಂಗ್ ಇಟ್ ಟೈಟ್ ಸ್ಟೂಡೆಂಟ್ ಹಲ್ಲು ಕಚ್ಚಿ ಟೈಟ್ ಆಗಿ ಹಲ್ಲು ಕಚ್ಚಿ ಎರಡು ಕಚ್ಚಿ ಇಟ್ಕೊಳ್ಳಿ ಹಲ್ಲನ್ನ ಜೆಂಡ್ರಿಸಿಂಗ್ ಮೆನೋವರ್ ಐ ಆಮ್ ಡೂಯಿಂಗ್ ಶೀಸ್ ಹೋಲ್ಡಿಂಗ್ ಟೈಟ್ ಇಷ್ಟೊಂದು ಟೈಟ್ ಹಿಡಿಬಾರ್ದು ಅದ ಲೂಸ್ ಬಿಟ್ಟಿದ್ದೀರಾ Yeah, anyhow, there I couldn't get right side. Let me see on the left side. ಕಾಲು ಮಡ್ಚ್ಕೊಡಿ ಹೀಗೆ ಇಟ್ಕೊಳ್ಳಿ ಹೀಗೆ ಲೂಸ್ ಬಿಡಿ left side also unable to get it, students. Unable to get it. Anyhow, L5 root we are thinking the involvement dorsiflexion, but even right side it is not coming. She is holding it very tightly. So the reflexes, bicep, triceps, brachial radius present on the right side. Okay, knee jerk is present both right and left side. Okay, actually it is brisk. Ankle jerk left and right I am not able to get it. Okay, right side is holding it tightly. I try to do with Jendrising maneuver. In spite of that, not able to get on right side. But we can explain on left side because there is a dorsiflexion, there is a weakness, L5 root, okay, and L5 S1 is the root value for the ankle jerk. We can explain on the left side. The other primitive reflexes are not present, no involuntary movements. Coming to the sensory system examination, again very important. Let me examine the sensory system examination. Okay, first I will examine the posterior column sensation, the fine touch, vibration, joint position sensation. Then I will examine the spinothalamic, the pain. First let me examine the fine touch. ಮುಟ್ದಾಗ ಗೊತ್ತಾದರೆ ಒಂದು ಅಂತ ಹೇಳಬೇಕು. Cervical region. Let me come to the hand. ಒಂದು ನಿಮಿಷ ಗೊತ್ತಾಗ್ತಾ ಇದೆಯಮ್ಮ? C8 T1 C8 so she can appreciate the C7 C8 T1 dermatomal distribution both up both right and left side. The other part I don't know to expose, but I examined, but it is normal. Okay, the upper limb examination is normal. Even the dermatomal distribution in the body is also normal till the T4, T6, T8 in the epigastric, T10 in the umbilicus, T12 in the suprapubic. It is normal. Even thigh also L1, L2, L3 is normal, students. Okay, I don't want to expose because she is a female. Only in the leg now I will examine. Okay, the sensory system. In the leg, students, the lateral part of the leg is supplied by L5. The dorsum is by S1. The medial part of the leg by L4. Okay, the medial part of the leg, the calf, the medial part of the calf by L4. The lateral part of the leg by L5. Dorsum of the foot by S1. And S2 supplies a small posterior region below in the leg. Let me examine in the L4 on the right side. L4, S1, L5. She can appreciate on the right side. Let me examine on the left side. L4 she can appreciate. L5 she can appreciate. Yeah, even here she can appreciate. Yeah, so you can appreciate. Sensation is normal. Okay, it is normal. The fine touch. Let me examine the vibration. Can take it, ಅಮ್ಮ ಇದು ಇಟ್ಟಾಗ ಇದು ವೈಬ್ರೇಷನ್ ಆಗುತ್ತಲ್ಲ, ಅದು ಟಚ್ ಮಾಡೋದಲ್ಲ, ವೈಬ್ರೇಷನ್ ಗೊತ್ತಾದ್ರೆ ಒಂದು ಅಂತ ಹೇಳ್ಬೇಕು. ಕಣ್ಣು ಮುಚ್ಕೋಬೇಕು.
ಒಂದು ಒಂದು ಒಂದು
Yeah, in the upper limb or the bony prominences, you can appreciate the vibration. Let me check in the lower limb now. Here she is not appreciating. Okay, let us see. Here she appreciates. Yeah, in the right. Let me examine the great of both the sides. She appreciates the right side. So here she is not appreciating, students. Okay, a very nice finding. And the left great toe, and the left lateral malleolus is not appreciating the vibration. Okay, so let us see the position sensation and joint position. Kantigiri Kamal avare. So she has appreciated the command whatever I have given. Let me check the position sensation. Kan muchkoli. ಈಗ ಎಡಗೈನ ಅದೇ ಥರ ಇಟ್ಕೊಳ್ಳಿ, ಬಲಗೈ ಯಾವ ಥರ ಇದೆ. ಯಾ, ಸೊ ಶಿ ಕ್ಯಾನ್ ಅಪ್ರಿಷಿಯೇಟ್ ದ ಪೊಸಿಷನ್ ಸೆನ್ಸೇಷನ್. ಓಕೆ, ಸಾಕು, ಕಣ್ ತೆಗೀರಿ. ಲೆಟ್ ಮಿ ಎಕ್ಸಾಮಿನ್ ದ ಜಾಯಿಂಟ್ ಪೊಸಿಷನ್ ಸೆನ್ಸೇಷನ್ ಇನ್ ದ ಲೋವರ್ ಲಿಂಬ್, ಇನ್ ದ ಗ್ರೇಟ್ ಟೋ. ಕಮಲ, ಫಸ್ಟ್ ಎಕ್ಸ್ಪ್ಲೇನ್ ಮಾಡ್ತೀನಿ. ಇದು ಕೆಳಗೆ, ಇದು ಮೇಲೆ. ಇನ್ನು ಕಣ್ಣು ಮುಚ್ಕೋಬೇಕು, ಆವಾಗ ಕೆಳಗ ಮೇಲೆ ಹೇಳಬೇಕು. ಕೆಳಗ ಮೇಲ, ಕೆಳಗ ಮೇಲ, ಕೆಳಗ ಮೇಲ, ಕೆಳಗ ಮೇಲ. Most of the times correct she is. Okay, the right side it is correct. Let me check on the left side. ಕೆಳಗ ಮೇಲ, ಕೆಳಗ ಮೇಲ. Most of the time she is wrong, student, so she is not appreciating here. ಮೇಲ ಕೆಳಗ, ಮೇಲ ಕೆಳಗ. Left side she is not appreciating properly. So left side there is a vibration is a problem. Okay, and joint position sensation is also a problem in the left dorsum of the foot. Okay, that is the finding. Let me examine the pain sensation. The pain sensation, here there are the sticks with a sharp edges is there. With this I'll touch, with this I'll examine the pain sensation. C7, C8, T1. C7, C8, T1. So upper limb normal, students. Let me examine the lower limb. Right side L5, L4, great also. So right foot is normal. Let me examine the left side. L5, L4 normal, she is not appreciating. Not appreciating. Okay, so dorsum of the foot again a problem. Okay, especially in the S1 root, she is having a problem. The vibration, the pain, the joint position. Okay, she is having a problem. She is saying one. See, students. She is appreciating. Yeah, so let us keep that findings. So students, these are the findings what you got. She couldn't appreciate the vibration in the dorsum of the foot in the great toe. A pain sensation she couldn't appreciate on the dorsum of the foot. Right. Then you have to look for a Romberg sign. I'll take her outside for a Romberg sign. I'll demonstrate that along with the gait. Okay. Then cortical sensation is normal apart from that area on the dorsum of the foot where she couldn't appreciate the sensation. In other part of the body, the cortical sensation is normal. So the Romberg sign, the gait and whether she could able to stand with the heel. That test is important because there is a dorsiflexion weak on the left foot. So left foot dorsiflexion is weak. So whether she can stand with the heel walking, or whether she can stand with the heel, that we'll check. Okay. And gait we'll check what sort of gait she is having, and Romer side when I take her to outside. Okay, all the three I'll demonstrate outside. And one more test is, because she has a problem with the dorsiflexion of the left foot, there are steps outside. I'll take her to steps. At the edge of the steps, I'll make her to stand with the foot hanging outside of the steps. A normal person will hold horizontally the foot, but because she cannot dorsiflex, the foot will drop like this and the steps. So I'll show that when I take her to the outside. These 4 signs I'll show outside. ಕಮಲ್ ಅವರೇ, ಎರಡು ಕಾಲು ಜೋಡಿಸ್ಬೇಕು. ಟಚ್ ಮಾಡಬೇಕು ಎರಡು. ಸ್ಟ್ರೈಟ್ ನೋಡಿ, ಕಣ್ಣು ಮುಚ್ಚಿ. Students, I am demonstrating the Romberg sign. Here she is standing with both the foot touching together, eyes closed, she is not falling. Romberg sign is negative, so it is not there. Romberg sign is a test for posterior column abnormality. It is not there. Okay, right. So next let us look for her gait. Bani amma ಈಗ ವಾಕ್ ಮಾಡಬೇಕು. ಸ್ಟೂಡೆಂಟ್ಸ್, ನೌ ಶಿ ವಿಲ್ ವಾಕ್. ಜಸ್ಟ್ ಅಬ್ಸರ್ವ್ her gait. Okay, the high stepping gait on the left side. Okay, first she will touch the front portion of the foot and then the heel, a double tap. Okay, that you will see now. The different types of gait are high stepping gait in a foot drop, stamping gait in a sensory ataxia. I showed in a Parkinson disease the fascinating gait. I showed in a hemiplegia patient the circumduction gait. Okay, and I showed in a cerebral ataxia SCA2 disease, which I discussed, the ataxic gait. So 4 types of gait you are seeing, students. So now today I will demonstrate the high stepping gait. Kamala, Bunny. See the left foot, how she is lifting it, students. See how she is lifting the left side, a high stepping gait. Again you see, students, the high stepping gait, the left foot, you can make out the high stepping gait. ಇನ್ನೊಂದ್ಸಲಿ ಬನ್ನಿ, ಸ್ವಲ್ಪ ಇಟ್ಕೊ. ಸಾಕು, ಬನ್ನಿ. See the high stepping gait. First she touches the front portion, a double tap will occur. Okay, a double tap. Yeah, again she'll go back. Just see her high stepping gait. Saku, enough. Students, now I will demonstrate in the foot drop whether she is able to stand with the heel. Okay, with the heel, whether she is able to stand. First with the right leg, I will tell her to stand like this with the heel. Okay, and then with the left leg, I will tell her to stand with the heel. But she is having a left foot drop. The right leg she can stand with the heel, but the left leg she cannot stand with the heel. Let us examine. Kamala avare, ನಿಮ್ಮ ಬಲಗಾಲ ಇದೆಯಲ್ಲ, ಈ ಥರ ಹಿಂಬಡಿಲಿ ನಿಂತ್ಕೊಳ್ಳಿ. ಹಿಂಗೆ ಬಲಗಾಲಲ್ಲಿ ನಿಂತ್ಕೊಳ್ಳಿ ಹಾಗೆ. She is able to do, students. You can make out that the right leg is normal. Let us do with the left leg. ಸರಿ, ಈಗ ನಾರ್ಮಲ್ ನಿಂತ್ಕೊಳ್ಳಿ. ಎಡಗಾಲ ಅದೇ ಥರ ನಿಂತ್ಕೊಳ್ಳಿ ಹಿಂಬಡಿ ಮೇಲೆ. ಆಗಲ್ವಾ? She is not able to do that. She cannot stand only on the heel, left leg, because of the foot drop. Okay, right. Students, now I'll ask her to stand in the steps. Okay, with the foot touching only the tip of the steps. Okay, I'll ask her to stand. Normal persons can stand horizontally with the foot. Whichever side there is a problem, there is a foot drop, the foot will hang down in the steps. Okay, I'll demonstrate that. Kamala, ಈಗ ಬಲಗಾಲ ಇದೆಯಲ್ಲ, ಬಲಗಾಲನ ಇಲ್ಲಿ ಈ ಥರ ಇಟ್ಟು ನಿಂತ್ಕೊಳ್ಳಿ. ಹಾಗೆ. She can do that. See, students, the right foot she is able to stand and it is horizontal. The right foot is horizontal. Now I will tell her to stand with the left foot. ಕಮಲ, ಈ ಕಾಲು ಹಿಂದ್ಗಡೆ ಇಟ್ಕೊಳ್ಳಿ, ಎಡಗಾಲ ಆ ಥರ ಇಟ್ಕೊಳ್ಳಿ, ಫುಲ್ ಟಚ್ ಹಾಗೆ ಇಟ್ಕೊಳ್ಳಿ. Students, you can see that the left foot is hanging down. It is hanging down. Okay, ಈ ಕಾಲು ಇಟ್ಕೊಳ್ಳಿ, ಬಲಗಾಲು ಸಮಕ್ಕೆ ಬರಲ್ಲ. ಎರಡು ಒಂದೇ ಸಲ ಮಾಡೋಕ್ಕಾಗಲ್ಲ. ಓಕೆ, ಸರಿ, ರೈಟ್. So left foot is hanging down. This is the test given in Dijon students. Okay. So next is skull and spine. Very important in this case. Some of the examinations in this patient where now she is having radicular pain in the left lower limb, which is asymmetrical. So what are the signs you check in skull and spine in this case? Okay. Let me demonstrate. First is a SLRT, and these tests usually you do for L5S1 for S1 route. L5S1 for S1 route you do all these tests. What is then nerve root compression, S1 root compression. First SLRT. SLRT I'll demonstrate. So I'll do the SLRT between 30 to 70 degree you do. If the patient experiences pain less than 30 degree of elevation, it is unlikely a organic, probably a functional cause. They are malingering. If it is less than 30 only, if they say pain. More than 70, a normal person may complain pain. So ideal is between 30 to 70 degree. 40 degrees most ideal. Now is another one. So there is no pain. She is not coming any pain. Okay. Now is another one. So no pain. SLRT is negative. And while doing SLRT, you have to look for any flexion of the knee will occur. That's called a buckling sign. If there is a pain, the flexion of knee will occur, and that's called the buckling sign. So you have to look for that buckling sign. And then you can, reinforcement can be done to this SLRT by dorsiflexion. So let me do the dorsiflexion. This is called as Bragard test. No pain. This is Bragard test, or you can just dorsiflex the toe. This is called a Sicard test. Dorsiflex the toe, Sicard test. I'll do on the left side again. SLRT, no pain. Let me reinforce. No idea? So no pain. And you dorsiflex the toe, Sicard test. So no pain. Okay. Next is Lesigue sign. Dijon says Lesigue and SLRT are just a modification. Some of the clinical books are different both. Okay, let me do the Lesigue sign. Amma, ಈ ಕಾಲು ಹಿಂಗೆ ಮಡ್ಚ್ಕೋಬೇಕು ಇಷ್ಟು ಆಯಿತಾ. ನಾನು ಇದನ್ನು ಮತ್ತೆ ಸ್ಟ್ರೈಟ್ ಮಾಡಿ ಇನ್ನೊಂದ್ಸಲ ಮಡ್ಚ್ಕೊಳ್ಳಿದ್ದು ಹಾಗೆ. ಸೊ ಫಸ್ಟ್ ಯು ಹ್ಯಾವ್ ಟು ಫ್ಲೆಕ್ಸ್ ದ ಹಿಪ್ ಟು ದ 90 degree and then you have to start extending the leg. You know idea? No pain. Okay? This is Lesigue sign, and you can reinforce by pressing the tibial nerve, okay, over the hamstring tendon. This is called a bowstring test. If there is a compression, they will have a pain. It is not there. Bowstring sign. I'll do on the left side. This is called marchukoli. Hageri. Then you have to flex 90. Then you have to start extending the leg. Yeah, like this. No idea? No pain. You can do a bowstring. You have to press the tibial nerve here. I am pressing it. No pain. Bowstring sign. Okay? Right. Right. So that is Lesigue sign and bowstring. Next is a flip test and for femoral nerve compression. I'll do a flip test on sitting position. First I'll demonstrate for femoral nerve for L2, L3, L4 how do you test for a femoral nerve compression. For that I have to make a prone position. I'll make a prone position. Okay, for a femoral nerve compression I'll do the test. Okay, you have to flex the knee. Only chana helidagama. You have to flex the knee joint. Okay, this is first, and then you have to try to extend the thigh. Illetti makalu. Yeah, like this. There is no pain on the left side. Right side I will do. Illetti kalu. She is doing it. No pain. So no femoral nerve compression. Aitu hige malkoli. Nidanike, no problem. So I will demonstrate how to do a flip test. Here the patient will be in a sitting position. You will extend the legs. Okay. Then if there is a pain, the patient will go back. He will flip back. Okay. So let me do that. Okay. I'm extending, but there is no flipping. Okay. She is not going in back. Okay, students. That's it. So that's how you do a flip test. Okay. The Schober test, I'll again demonstrate outside the Schober test. Okay. So these are the examination findings. Students, in a lumbar canal stenosis, you have to do a Schober test. I don't want to expose her, she is a female, so I won't remove the cloth, but just I'll tell the method how to do a Schober test. Okay, first you have to upper part of the lumbar vertebra, the L1 vertebra, the upper part of the lumbar vertebra, L1 vertebra, you have to take a 5 centimeter below that. For example, if the lumbar vertebra is here, a 5 centimeter below, you have to mark here, mark, okay, and then 10 centimeter above that. 10 centimeter, you mark this side, 10 centimeter above that. So here there are two markings. Now you have to ask the patient to bend down. Kamala, full bend agi, extra bend agi. Yeah, bend down. Okay, now she has bent down. Then you have to measure the distance between the two markings. So students, I will demonstrate how to do a Schober test. So from the upper part of the lumbar vertebra, 5 centimeters below, 10 centimeter above, you have to mark a line. Then ask the patient to bend forward as far as she can. Then at least 5 centimeter expansion should be there. Okay, then those 2 points should become at least from 50 to 20 centimeters. So because she is a female, I don't know to expose, I'll just show the method how to do it. Okay, so suppose if this is the lumbar vertebra, 5 centimeters below, you have to mark a line. She has marked here. Okay, then 10 centimeters above that, you have to mark a line. She has marked here. Then you have to just 15 centimeters and ask the patient to bend. Let her bend now. Amma, mundu bend agi eshtu aguthe eshtu? She is bending it. Okay. Now this has become centimeters. Okay. So the other system examination, CVS, RS, per abdomen, NAD. Okay. So what are the positive findings you got at the end of examination? So on the end of examination, the positive finding is there is a motor weakness, a dorsiflexion of the left foot. There is dorsiflexion, there is a weakness. Even inversion, eversion, there is a weakness of the left foot. Extensor hallucis longus, there is a weakness. Sensation, vibration in the S1 root distribution. Pain sensation in the S1 root distribution, there is a absent. Plantar is flexor, very important thing. And both the knee jerks is brisk. Left ankle is absent. Right ankle also she was holding it tight. I couldn't get the right ankle reflex. Okay. So you thought at the end of history there is a radiculopathy. Okay, because from whole lower limb she was having a pain, a lancinating pain, electric shock like sensation. And she developed the motor weakness after the operation in 2009. So we thought a spinal radiculopathy because of the compression plus a foot drop. And your examination finding is also fitting into a foot drop. There is dorsiflexion, there is a weakness. And even on the S1 root, there is absent sensations. You are seeing it. The vibration, the pain is lost. So with this, what are the investigation they have done? Okay, so the L5 is the dorsiflexion of the foot. So L5 root will be involved. And even S1 is involved because there is absent sensation there, pain sensation is absent there. So S1 L5 root, our clinical diagnosis. L5 root and S1 root. Let us see in the examination which part of the spinal cord, which level, what is involved. So investigation of choice, as you know, all of you know, it is MRI. So MRI of the lumbar spine they have done. It is showing spinal canal and its diameter. The diameter at the L1 level is 10 mm. At L2 level is 10 mm. At L3 level is 9 mm. At L4 level 9 mm. L5 level 9 mm. Any anteroposterior diameter less than 12 mm in lumbar region is a lumbar canal stenosis. So she is having a lumbar canal stenosis, okay, from L1 to L5. And there is a ligamental flavum thickening noted at L4 and L5 level. So there is lumbar canal stenosis. Let us see the disc, what has happened. L1, L2 is normal. Anyway, clinically we didn't get any L1, L2 signs. And symptom also, it was not there. L2, L3, there is a diffuse disc bulge noted causing moderate thecal compression, that's all. L2, L3, there is a moderate thecal compression. So L2, L3 means L3 will be involved, root, and here there is no any signs we got in L3. L4, L5 and L3, L4. there is a diffuse disc bulge causing moderate thecal sac compression and bilateral foramen narrowing. So if L4, L5 root will be involved, she is having the problem in the L5. That's why dorsiflexion of the foot is a problem. L5 root, if it is involved, they'll have a foot drop. So L4, L5, there is a diffuse disc compression. L5S1 also there is a problem. Diffuse disc bulge noted causing mild thecal compression and left foraminal narrowing, left side only. That's why left side, that sensation in S1 distribution lost. The vibration, the pain, S1 root. And L5 root, dorsiflexion is involved. So clinical signs will always correlate with your examination, students. Scaneous is such a wonderful thing. Your history and history is 90%, 19% enough. Another 5% your examination will add to it for your diagnosis. So the impression is disc bulge at multiple lumbar levels causing thecal sac compression and foraminal narrowing. The impression is severe lumbar canal stenosis, posterior central and left posterior inferior disc compression at L3, L4 level. So that is L4 root producing a problem, and even L5S1 causing gross compression and thecal sac and left lateral recess nerve roots. Posterior central circumferential annular tear with posterior central and bilateral paracentral disc protrusion at L4, L5 level. That is why L5 root is involved, causing significant impression on the thecal sac, bilateral lateral recess and proximal foraminal nerve roots. Okay. Then they have done a nerve conduction study in one of the hospital in Bangalore for that whatever the problem she had left dorsiflexion problem. So the features nerve conduction study has suggested you have left common peroneal motor axonal neuropathy. Okay. And in that study, bilateral sural and superficial peroneal nerve study is normal. Sensory is normal in the nerve conduction study, but clinically we got the sign. Definitely there is a vibration is affected, pain is affected. The nerve conduction study is showing only motor, the left common peroneal nerve. That is a foot drop. That is why she is having it, axonal neuropathy. Okay. And they have done a MRI. That MRI signs I will show in the view box. Okay. The classic disc protrusion and compression at L5S1, L4, L5, L3, L4 level. Classically it is present, all the MRIs I will show. So, this is the investigation what they have done. And students, after the operation, she told she has developed this weakness, the dorsiflexion of the foot. It could be iatrogenic or it could be because of a problem, whatever she was having, a lumbar stenosis, the cause for the foot drop. We don't know. But because probably she's telling the next day only after operation, she developed this. One of the causes of foot drop is laminectomy producing iatrogenic injury to L5 root. Okay, it could be, most probably that could be the cause for a foot drop. So students, this is the MRI of the same patients with the nice findings. I'll demonstrate. See, this is a sacrum. This is L5, L4, L3, L2, L1. You can see here between L5 and S1, this is the disc which is pressing on the spinal cord. But see here between L4 and L5, there is too much pressing. The disc is protruding into the spinal cord. Okay. So that is why the predominantly L5 root is involved, producing a foot drop in her. Though she has even S1 findings. Okay. But predominantly L5 and even between L3 and L4 producing L4 also. See here the spinal cord is pressed and even here in the one space above. But here all it is normal in the above spinal cord. Okay. The same thing you can make out here the canal diameter. The canal diameter, this is sacrum, this is L5. Between L5 to L2, it is around 9 to 9.7 mm. The AP diameter less than 12 mm is lumbar canal stenosis. So there is a lumbar canal stenosis because of the disc degeneration extending into the multiple levels. Here also you can make out students, the disc is protruding into the spinal cord here. Okay. Okay. Here it is protruding. And here you can make out the disc is protruding here. It is protruding here between L5, L4 and L5. Between L4 and L5. Okay. This is L5 and this is sacrum. This is L5 and this is sacrum. This is L4 and L5. This is L3 and L4. Here also it is pressing. Okay. Right. I'll show the other MRI diagrams. So again students, you can make out here, this is L5, this is sacrum, the disc is prolapsing here. Here also prolapsing between L4 and L5, there is a disc prolapse. So yes, student, this is sacrum, this is L5, the disc is protruding here. The more protrusion here between L4 and L5, so that is why L5 root is damaged. Okay, here also you can make out this is sacrum, this is L5. Between L4 and L5, there is severe pressing on the spinal cord, producing a L5 root. That is why the foot dropped. Okay, so same thing here. So let me discuss about the case. Okay, some detailed discussion about the spinal cord, compressive myelopathy, non-compressive myelopathy, lumbar canal stenosis, lumbar disc prolapse, and some of the standard question what they'll ask in the exam for you people. For the compression, the most common causes are trauma, tuberculosis, lumbar and cervical spondylosis, and secondaries are the most common causes for a compressive myelopathy. The less common causes are inherent causes like osteoma, sarcoma, myeloma. Okay, the less common causes are sarcoma, myeloma, osteoma, and even hemangioma. The very rare causes are achondroplasia and severe kyphoscoliosis. The very rare causes. Then your other causes for a extramedullary compression by a extradural abscess can come and compress. Then granulation tissue by sarcoidosis, tuberculosis. Then arachnoiditis. Arachnoiditis is subarachnoid space will become inflamed, producing a granulation tissue that is known as arachnoiditis. Arachnoiditis, the two important causes are syphilis and tuberculosis. Arachnoiditis, granulation tissue, sarcoidosis, and tuberculosis. Then meninges, meningeal metastasis by the leukemias, or there can be a cyst, arachnoid cyst pressing on the spinal cord, or a parasitic like hydatid cyst or a neurocystic sarcosis can press on the spinal cord, producing a compression. There are some other causes of compressive myelopathy. In her, what is producing compression? Lumbar canal stenosis and lumbar disc disease in her. That is the cause of compression. As I told, that is one of the commonest cause. In India, other common is tuberculosis and trauma. So this is about the compression. Now, what are the causes of non-compressive myelopathies? Non-compressive myelopathy infecting the viral infections, the HIV, rabies, influenza virus, Epstein-Barr virus, cytomegalovirus, herpes zoster. Then immunoallergic, in that influenza vaccinations for measles, chickenpox, rubella, or rabies vaccination, tetanus, polio virus. These vaccinations can produce a non-compressive myelopathy. Then a bacteria, two important causes in India, tuberculosis and syphilis. Fungal, actinomycosis. Parasitic, you have toxoplasmosis, malaria, schistosomiasis. These are the cause of infectious cause of non-compressive myelopathy. Then you have toxins like arsenic, letharism, then triarthocracyl phosphate (TOCP), intrathecal penicillin, anesthesia, and SMONs, submyelooptic neuropathy. Some other toxinous causes of non-compressive myelopathy. Then you have vascular etiology, atherosclerosis, abdominal aortic aneurysm, vasculitis, or spinal AV malformation, angiomas can produce a vascular etiology of a non-compressive myelopathy. The nutritional metabolic causes, pernicious anemia, pellagra, renal failure as a metabolic cause, HTLV infection, paraneoplastic syndromes can produce a non-compressive myelopathy. Then hereditary cause. Hereditary cause is hereditary spastic paraplegia. A motor neuron disease can produce a paraparesis. And spinocerebellar ataxias can involve the corticospinal tract, producing a paraparesis. So those are the hereditary causes. So you have, and then a demyelinating diseases like multiple sclerosis can produce a tannus myelitis and non-compressive myelopathy. Along with that, optic neuritis, which is called as a Devick's disease, and subacute combined degeneration with the B12 deficiency can produce a weakness of the lower limbs, subacute combined degeneration, a demyelinating disease. Transverse myelitis will be usually of a three etiologies. One is either an infection or immunization or a demyel. So the non-compressive myelopathies are, as I told, infective, immunologic, demyelination, heredofamilial, toxins, vascular etiology. Then some of the physical agents like radiation or electrocution can produce a transverse myelopathy. In India, two important diseases you have to consider in a compressive myelopathy or even a non-compressive myelopathy also. One is tuberculosis and syphilis. Tuberculosis can affect the spinal cord in two forms, in a primary spinal form or secondary to the CNS meningitis or involved in the vertebral body. The thoracolumbar region is the commonest cause of tubercular compressive myelopathy or even non-compressive myelopathy. I will tell what are the ways to produce non-compressive myelopathy. Tuberculosis affects the spinal cord because of it can be a caries of the vertebra, a granulation tissue, cold abscess, tuberculoma, or it can involve the vasculitis producing a non-compressive myelopathy, tubercular vasculitis, or a tubercular myelitis, inflammation of the spinal cord because of tuberculosis, tubercular myelitis, or arachnoiditis, where inflammation of the subarachnoid space producing granulation tissue pressing on the spinal cord. So, caries, granulation tissue, tuberculoma, cold abscess, vasculitis, arachnoiditis, tubercular myelitis. A standard question, one more standard question, students in the exam, they'll ask this. What are the ways tuberculosis will affect the spinal cord? So, you should know about this. So, next is syphilis. Syphilis can affect the CNS and the spinal cord. It affects CNS and spinal cord by three pathological processes. One, by subacute meningitis. Two, by vasculitis. Third, by gumma formation. First, the brain, it can affect the dura mater, that is patchy meningitis. They'll have altered level of consciousness, convulsions, and hemiparesis they can have. Then CNS, leptomeningitis. They'll have multiple cranial paralysis, optic atrophy, convulsions, and because of the vasculitis, they can have a stroke. And even gumma can occur in the CNS. This is the central nervous system. Then spinal cord, you can involve the dura mater producing the patchy meningitis, cervical patchy meningitis. See, whenever dura is involved, it is patchy. Arachnoid and pia, it is lepto. Then one more important entity which they ask in the exam is what is Erb's spastic paraplegia. This Erb's spastic paraplegia you get in syphilis involving the spinal cord, that is leptomeningitis. That is meningomyelitis, where there will be a compression of the spinal cord because of meningomyelitis, producing a pure spastic paraplegia with bladder involvement. This CNS involvement is seen in usually tertiary syphilis students, whether spinal cord or the CNS. Then spinal cord, it can involve the vasculitis producing anterior spinal artery thrombosis, where they'll have a dissociate anesthesia with the bowel and bladder involvement, sudden onset of paraparesis or quadriparesis depending upon the level of vasculitic obstruction. Tape's dorsalis, it occurs 8 to 12 years after the primary infection, usually common in 30 to 55 years of age groups. In Tape's dorsalis, dorsal root ganglia will be involved. There will be degeneration of the dorsal root ganglia and the dorsal root nerves. So, they'll have a lancinating pain will be there, absent ankle reflex, proprioception, vibration will be absent and joint position will be absent. They'll have Argyll-Robertson pupil, optic atrophy. Then Romberg will be positive, Rombergism will be there because of posterior column involvement, and ankle reflex will be absent. That is Tape's dorsalis. And even you can have a fifth and ninth nerve affection in Tape's dorsalis. Fifth and ninth nerve affection. Okay, right. So the two important diseases which we will consider, as I told, is tuberculosis and syphilis. Okay, right. Then next point is after discussing that, in this compressive, non-compressive, how do you distinguish? I told. Compressive myelopathy, asymmetrical root pain. Non-compressive, no root pain, symmetrical. Then in the compressive myelopathy, whether it is intramedullary or extramedullary. What are the differences between intramedullary and extramedullary? Pain in an intramedullary is funicular pain, whereas a root pain in extramedullary, radicular pain. The sensation absence in extramedullary is ipsilateral fine touch, contralateral pain and temperature, whereas in intramedullary, loss of pain and temperature, dissociate anesthesia. Sacral sparing is a feature of intramedullary because sacral fiber is situated laterally in the spinal cord, whereas that saddle anesthesia is an early involvement in extramedullary compression. And element size is predominant in intramedullary compression at that level because of fasciculation, wasting, whereas the human size are predominant in extramedullary compression with a DTR exaggerated spasticity. Tropic ulcer is a feature of intramedullary compression, not a feature of extramedullary compression. These are some of the differences between intramedullary and extramedullary compression. The other point which in this you have to discuss is whenever the compression occurs on the spinal cord, it produces the effect by four mechanisms. It may press on the arterial circulation, it may produce a venous congestion, or it may directly press on the neural structures, or a CSF obstruction producing Freund syndrome. So whenever there is a compression, it can press on the dorsal column producing a girdle-like of sensation, a band-like sensation, a posterior column compression, band-like sensation. It may press on the root producing a radicular pain, or it may press on the anterior horn cell producing a wasting at that level, at that segmental level, or it may produce the UMN signs in the lower limb. Okay, so you have the compression, anterior horn cells, posterior root, posterior column, and pyramidal system. So because it presses on the pyramidal system, they will have a UMN signs in the lower limb. So all these things will have because of the compression. Then next is the lumbar disc prolapse and lumbar canal stenosis. Few points about that. What is the difference between lumbar disc prolapse and lumbar canal stenosis? The age of onset in lumbar disc prolapse is 3rd to 4th decade, whereas 4 to 6 decade in lumbar canal stenosis. The mode of onset is acute in lumbar disc disease, whereas chronic in lumbar canal stenosis. The pain in both the cases will be in the back and lower legs. Then SLRT will be positive in a lumbar disc disease but not in lumbar canal stenosis, SLRT. Okay, right. Then the relieving things. In a sitting posture, the pain will exaggerate in a lumbar disc but not in a lumbar canal stenosis. Lumbar canal stenosis, sitting position, pain will get relieved. Then neurological claudication. The neurological claudication may be present in lumbar disc prolapse, but it is definitely acutely present in a lumbar canal stenosis. I'll tell a few points about lumbar canal stenosis and disc, and then I'll tell the difference between neurological claudication and a vascular claudication again. Lumbar canal stenosis, as I told, it occurs in 4th to 6th decade. It's a congenital narrowing of the lumbar canal, which will be aggravated by the degenerative process of the disc. So whenever patient stands, the disc will protrude, exaggerating the symptom, or whenever patient walks, there will be hyperemia, producing the exaggeration of the symptom. It is one of the most commonest cause of cauda equina syndrome. L4, L5 is the commonest site of obstruction. It can be aggravated by achondroplasia, acromegaly, and spondylolisthesis. So they'll have a neurological claudication. Males are more affected than the females. So they'll have pain in the leg, gluteal region, and thigh. And if you ask the patient to walk, the provocative test, they'll have a pain. Neurological claudication will be there. And if you ask the patient, even after developing neurological claudication, to walk, they'll stoop down and walk. All those points we asked him, whether she stoops down after walking for some time, she didn't tell no. Then other signs what you get is there will be a spasm in the lumbar region. The lumbar lordosis, the normal lumbar lordosis will be lost and they'll have a stooped posture and absent ankle reflex. These are the signs what you get in lumbar canal stenosis. Then AP diameter should be less than 12 mm. Our patient had in MRI, the AP diameter of the lumbar canal was around 9, 10. So less than 12 is the lumbar canal stenosis. Probably she developed that because of the disc degeneration at multiple levels. Then you have to do a Schober test. Schober test, I demonstrated how to do it. At the upper level of lumbar spine, 5 cm below, 10 cm above, you will mark up 2 points and ask the patient to bend down as far as possible. Then that 15 cm, whatever the distance, should become 20 centimeters minimum. That is a normal. But in lumbar canal stenosis, that won't happen. So Schober test. So you have to do a Schober test. Coming to the lumbar disc prolapse, it occurs at 20 to 40 years of age groups. They'll have a radicular pain, a pain in the leg, buttocks and thighs. So the commonest site of disc prolapse, lumbar disc prolapse, is L4, L5. If the disc prolapse occurs at L5, S1, the root involved is S1, there will be a problem with the plantar flexion of the foot, See, our patient, she had the medial part of the foot, loss of sensation, but plantar flexion was not affected. In her, plantar flexion was normal. The next is L4, L5. In L4, L5, L5 root will be affected. In a L5 root, there will be a dorsiflexion will be affected. The dorsiflexion of the foot will be affected. And in L5 root, the lateral part of the leg will be affected. And dorsum of the foot also will be affected, the sensation in L5 root. So, S1 root, plantar flexion will be affected, ankle jerk will be absent, lateral part of the foot there will be absent sensation. L5 root, dorsiflexion will be affected, lateral part of the leg will be affected, the sensation, and dorsum of the foot will be affected. Then L3, L4 root will be affected, medial part of the leg will be absent sensation, then the thigh musculature will be affected. And medial part of the foot sensation will be affected in L4. And here, not the ankle jerk, knee jerk will be absent in L4 root. This is how you localize the root disc, whenever which root is damaged, what signs they will have. See, a dorsiflexion is affected, our patient, so L5 root. Okay, students? Dorsiflexion is affected in our patient, so L5 root. If S1 root is there, as I told, heel and posterior part of the calf will be affected, and in L5 lateral part of the foot will be affected, the sensation, as I told. L4 is medial part of the foot. And different tests for these disc prolapse, I demonstrated the SLRT. Between 30 to 70 you can do, less than 30 is usually a functional, 40 is ideal. You can reinforce with the dorsiflexion of the foot, that is Bragard test, or dorsiflexion of the great toe, Sicard test. You can do Lesigue test. You can do Bosting test by pressing for the tibial nerve while doing a Lesigue test. Then flip test, I demonstrated, to make them sit. Just extend the legs, they'll go back. Then buckling sign while doing SLRT, you will see they'll buckle, the knee will buckle, flexes because of the pain. And for a femoral nerve test, I made a prone, flex the knee joint and extended the thigh. These are the tests what you will do in a disc, especially L5, S1 for S1 root compression, you will do these tests. Okay, students, right. So now, I just want to tell the vascular claudication and neurological claudication, the difference once more. Neurological claudication, the pain will be buttocks, thigh, posterior part of the thigh, leg. Vascular claudication, calf. Neurological claudication, it can be bilateral, vascular, unilateral. Aggravating and relieving factors. Stepping up, vascular will have a pain. Stepping down, neurological claudication will have a pain. Standing for longer period, cocktail party, neurological claudication. And bicycle testing. Bicycle will produce a pain in a vascular claudication but not in a neurological claudication. Bicycle testing. Then associated symptoms, paresthesia, priapism, incontinence is a feature of neurological claudication, not a vascular claudication. Then after making the patient exercise, there will be a weakness and absent reflexes in a neurological claudication but not in a vascular claudication. Then pulses, absent in a vascular claudication but not in a neurological claudication. These are all standard questions, students. You should be in fingertips as a postgraduate students. Then conus cauda and epiconus you have to know while discussing this. Again, I'll repeat the conus cauda, the conus and cauda. Conus is S3, S4, S5. Cauda is L1 to all the roots downwards. Conus, the pain will be symmetrical, saddle anesthesia, and there will be dissociative anesthesia in saddle, in conus. Whereas in a cauda, it is asymmetrical, a root pain will be there, radicular type of pain, and all modalities will be lost. Bowel and bladder, prominent involvement in conus but not in cauda. Sexual function, bowel bladder involvement in a conus but not in cauda. The muscle weakness is not a feature of S3, S4, S5 conus because it usually doesn't supply any muscles, S3, S4, S5. Whereas in a cauda, it supplies the muscles, the roots, L4, L5, thigh muscles. So there will be a wasting is a feature of cauda equina lesions. And fasciculation is a feature of conus but not cauda equina. Conus will be usually acute lesions, cauda equina will be a chronic lesions. This is conus and cauda, again they last standard, but clinically you won't get separate. A mixture will be there, that is called conocauda lesions. And as I told, dissociative anesthesia is a feature of conus but not a cauda. That is important. Then conus and epiconus. In conus and cauda only. In conus, ankle reflex will be absent. Cauda, ankle and knee jerk will be absent. Because L3, L4, L5 knee jerk. Conus, only in epiconus ankle will be absent but not in a conus. Okay. Epiconus is L5, L4, S1, S2. Conus is S3, S4, S5. So the difference between conus and epiconus is the bladder, bowel, sexual disturbances is not seen in epiconus but is seen in conus. And ankle reflex absent in epiconus but not in conus. Then, depending upon the absent sensation, whether you can localize in the spinal cord, what part is involved. Some of the syndromes, for example, the patient has a Brown-Sequard syndrome. They will have ipsilateral fine touch loss, contralateral pain and temperature. That is Brown-Sequard. Suppose if dissociative anesthesia, pain and temperature is lost, but fine touch vibration preserved, then intramedullary tumor. Suppose if only at one level, segmental level, there is a loss of sensation, above and below that is normal. Central cord syndrome. At that level, there will be a loss of sensation, but above and below will be normal, central cord syndrome. Then anterior spinal cord syndrome. For example, in anterior spinal artery thrombosis, there will be a loss of pain and temperature, but posterior column sensation will be preserved. It is anterior spinal artery syndrome. Then, for example, if below one level everything is lost, fine touch, vibration, position, joint position, that is thoracic syndrome. At one level everything will be lost. Then one more is dorsal column syndrome given in De Jong. There will be a loss of position and vibration sensation with preserved ankle reflex. That is dorsal column syndrome. Then saddle anesthesia. If one patient says surrounding the anal region there is absent sensation. So where is the problem? Saddle anesthesia, cona cauda. Very simple. Depending upon the type of the sensory abnormalities, you can localize it. I have discussed this already in the general examination also. It is just a revision for you. And in thalamus, if right thalamus is involved, whole side of the body, left thalamus will have a problem. And if peripheral nerve is involved, glove and stalk anesthesia added to the spinal cord. So if glove and stalk is there, it is not spinal cord. If one side of the body full is affected, it is not spinal cord. That's how you localize the spinal cord. The De Jong has given in the last chapter, students. So, the other points what you should know in this case, I'll discuss few points about even paraparesis. When I discuss transmyelitis and one more spastic paraplegia I'll discuss. I'll repeat the paraplegia discussion in that also because some of the points are very important. The paraparesis students, it could be problem in the cerebral cortex, spinal cord, root, peripheral nerve or the muscles. Anywhere paraparesis they can develop. The central cause of paraparesis are you have ACA anterior cerebral artery, it can be unpaired, that can get blocked, or a bilateral ACA can get blocked, or a parasagittal tumor, or a parasagittal trauma, or after delivery in a postpartum, you have a cortical venous thrombosis. They can have a paraparesis, central cause of paraparesis. So you will have a cortical sensation will be lost and fits, Jacksonian fits can be there in the central cause of paraparesis. The most common cause of paraplegia are trauma, tumor, tuberculosis, thrombosis, okay, and transverse myelitis. The most common cause of paraplegia. Again, I will discuss about paraplegia in detail when I case the next two cases are paraplegia only. Here, just with this case because it is compressing in the spinal cord, here it will be only radiculopathy. It is not pressing on the myelitis. It is not pressing on the spinal cord. Only in the root it is pressing. Suppose if it should have pressed on the spinal cord, she should have developed a stiffness, plantar extensors, and hypertonia. Then one more standard question, what they'll ask when you get a paraplegia is paraplegia in flexion and extension. A standard question. Normally, the tone is maintained by cerebrum, the spinal reflex arc, the corticospinal tract, extrapyramidal symptom and cerebellum. So, whenever the corticospinal tract alone is affected, okay, then usually the reticulospinal tract of the extrapyramidal will become more activated. So, then they produce anti-gravity muscles more tone. Anti-gravity muscles in the lower limb is extension. So, they will have paraplegia in extension. Whenever only corticospinal tract is affected but no extrapyramidal system. Even if extrapyramidal is also affected along with corticospinal tract, then the local reflex arc will become more prominent. It produces hamstring contraction, iliopsoas contraction, producing paraplegia in flexion because of a local spinal reflex arc. So, what are the difference between paraplegia in flexion and extension? Paraplegia in flexion is a complete transaction. Extension is an incomplete transaction. Extrapyramidal also will be involved in paraplegia in flexion, not involved in extension. Extension is a acutely developing, flexion is a chronically developing. Then two important things, flexor withdrawal response is a feature of paraplegia in flexion. That means if you do a plantar, they will withdraw the leg with a triple flexion. Flexion of the thigh, flexion of the knee, dorsiflexion of the ankle, flexor withdrawal response. And Morse reflex, again one of the fascinating questions of the exams. Morse reflex is a feature of paraplegia in flexion. What is Morse reflex? Whenever you do a plantar reflex, there will be evacuation of the bowel and bladder along with ejaculation. That is Morse reflex. So, Morse reflex and flexor withdrawal response is a feature of paraplegia in flexion. Again, these things I will repeatedly discuss next 3 classes continuously, students, because if you know these questions answer, you are passed in the practicals. Today, what I discussed, the difference between compressive and non-compressive myelopathy, intramedullary and extramedullary compression, neurological claudication, vascular claudication, conus cauda, conus epiconus, Morse reflex, paraplegia and flexion and extension. You are passed if you know the answer for these questions. Whenever you get a spinal cord case. Okay, so that's about paraplegia and flexion and extension. So usually in the initial stage there will be a flaccid paralysis whenever a human paraplegia will occur. Sometimes this spinal shock stage may extend whenever there is a UTI, a bed sore, or a malnutrition, stress and strain. At that time, this flaccid stage can extend in paraplegia. So that point you should know. Okay. Then after discussing all these things, you should know a little briefly about anatomy. Some examiners, not some, most of the examiners, they'll ask anatomy of the spinal cord. Brief, you should know about the anatomy. It has 31 nerves, 8 cervical, 12 thoracic, 5 lumbar, 5 sacral, 1 coccygeal. But there are only 7 vertebra, cervical, but 8 cervical roots are there. So till C7, the root will come out by above the corresponding vertebra. For example, C7 vertebra, the C7 will come above the C7 vertebra. C8 will come below the C7. Then T1 will start coming below the T1, T2 like that. That you should know. Till C7 above. After that T1, it is below, it comes the roots. They exit out of the vertebra like that. Okay. So then you should know little bit briefly about what is the relation between the spinal cord and the vertebra. This also they will ask. Okay. If it is a lower cervical, you will add 1. Okay. The spinal cord segment, in the vertebral segment, if it is a lower cervical, the spinal cord segment, you will add 1. Upper thoracic, you will add 2. That is 1 to 6. You will add 2. Lower thoracic, 7, 8, 9, you will add 3. Then T10 corresponds to L1. L1, L2. That T10 will correspond to L1, L2. T11 will correspond to L3, L4. And T12 will correspond to L5. And L1 will correspond to sacral and coccygeal. So this relation you should know anatomically between the spinal cord and the vertebra. Then brief about the blood supply. It has 1 anterior spinal artery, 2 posterior spinal artery. Anterior spinal artery given by vertebral artery. Posterior spinal artery is also given by vertebral artery. Vertebral artery will give 2 anterior spinal joined together to form 1 anterior spinal artery. Then you have artery of Adamkiewicz. It is the biggest artery which reinforces the spinal circulation. It is present in the lower thoracic and lumbar region. It is mainly present on the left side of the spinal cord. Artery of Adamkiewicz. Okay. So that's about the blood supply and some of the vascular syndromes of the spinal cord I'll tell. Okay. If an anterior spinal artery is occluded, then they'll have a dissociate anesthesia, bowel and bladder will be involved, posterior column sensation will be spared. A sudden onset of paraplegia or quadriplegia they may develop. Anterior spinal artery can occlude because of vasculitis, abdominal aortic operation, coarctation of aorta repair, cardiac embolism, vertebral artery dissection, hematomylia, or atherosclerosis or abdominal aortic rupture. All of these things can produce anterior spinal artery ischemia. Posterior spinal artery, if it is occluded, the dorsal column will be affected, pain and temperature will be spared. These are arterial syndromes. Then a brief points about the foot drop, whatever she had, the foot drop. The unilateral foot drop is usually produced by either a L5 radiculopathy or a common peroneal nerve injury. L5 radiculopathy or common peroneal nerve injury. A bilateral foot drop is a feature of motor neuron disease, Charcot-Marie-Tooth disease, which is a hereditary neuropathy, hereditary motor sensory neuropathy, or a severe peripheral neuropathy, where the distal muscles will be weak, both the sides, right and left. Or some of the myopathies. Usually myopathies will produce a proximal muscle weakness, but there are some rare distal myopathies which can affect the muscles, producing a bilateral foot drop. So bilateral foot drop, some rare distal myopathies, severe peripheral neuropathy, motor neuron disease, Charcot-Marie-Tooth disease, which is a hereditary motor sensory neuropathy. Bilateral foot drop. In a foot drop, as well as sensory ataxia, you will have a high steppage gait. In a foot drop, the front part of the foot touches the ground first, then the heel, producing a double tap, which produces a different sound from that of a stamping gait of a sensory ataxia. In a severe peripheral neuropathy, they can have both a sensory gait ataxia as well as a high steppage gait because of a foot drop. That is a peculiar condition where a severe peripheral neuropathy, sometimes they can have both a stamping gait as well as a high steppage gait of a foot drop. Then this comparal nerve can be involved by a mononeuritis because of diabetes, because of vasculitis, because of rheumatoid arthritis, leprosy, or after a bariatric surgery because of B12 deficiency. And iatrogenic, like in our case after laminectomy or even a knee replacement, they can develop a common peroneal nerve injury with a foot drop. Like our case, after laminectomy, she developed immediately the foot drop. Okay, so those are some of the points. Even lumbar, you have a lumbar plexus. So if any injury to lumbar plexus also, they can develop a foot drop. Lumbar plexopathy can develop the foot drop. Leprosy, we look for the thickened nerves and skin lesions. Again, that can produce mononeuritis, leprosy. That also one of the cause for foot drop. So this is a discussion about compressive radiculopathy, lumbar canal stenosis, and foot drop. What this patient had. I discussed brief about anatomy and also some of the standard questions which I will ask him, get a spinal cord disease like this. For another next 2 or 3 cases, I will discuss spinal cord only. 2 paraplegia cases I will discuss. Again, same thing I will repeat so that it will imprint in your brain, because if you know the answer to these questions, you are passed in the exam students, standard questions. Okay? Thank you, students.